Hello, everyone. Thank you for joining us. Today, we are presenting MRHN's Connected Care 2026 strategy. As part of this strategic initiative, MRHN aims to strengthen its health IT infrastructure and improve interoperability, EHR integration, and consumer engagement. MRHN is a recognized leader in health IT adoption and has made significant enhancements in its health information system implementation. We have a wide network across urban, suburban, and rural areas serving over 1.2 million patients. Our goal is to modernize our digital ecosystem to deliver more connected, equitable, and proactive care. Our urban facilities have high ERM maturity, but rural hospitals still rely on legacy EHRs without real-time interoperability. Data silos, compliance challenges, and engagement gaps remain. Connected Care 2026 aims to close these gaps through interoperability, CDS integration, better care coordination, and a 30% increase in consumer engagement over 2 years. Our assessment identifies several interoperability gaps across the network. Epic, our enterprise system, has strong adoption in our urban sites, but rural hospitals remain on legacy systems with no real-time exchange. Behavioral health notes and remote device inputs are captured inconsistently across sites, and connectivity and bandwidth in rural areas limit reliable data exchange.
We assessed maturity across MRHN using the HIMSS interoperability model. At the foundation level, rural clinics on legacy systems can't exchange data in real time and bandwidth compounds it. So we recommend migrating them to Epic Care Ambulatory and expanding broadband. Structurally, behavioral health nodes and remote monitoring inputs arrive in non-standard formats that aren't FHIR or HL7 compliant. Configuring documentation templates to DAP and BOB standard fixes that at the source. Semantically, external exchange through Epic Care Everywhere is limited and interface standards vary by site, so we recommend common data models, converting device data to FHIR observations, and enforcing SNOMED, LOINC, and RX norm standards. Organizationally, MRHN has real strengths, stage 6 and 5 maturity, and an established enterprise task force. The barriers here are cultural and procedural. Resistance to patient-generated data, low MyChart adoption in rural areas, inconsistent workflows, and lack of data governance policies, access, and security. We recommend unified interoperability governance, consumer engagement incentives, and TEFCA and HIE participation to formalize cross-institutional collaboration. Our proposed architecture connects inpatient, outpatient, and rural sites through a centralized FHIR HL7 API gateway, which sits between the Epic environment and the outside world. External systems, laboratories, and consumer wearables all connect through FHIR R4 and HL7 version 2.5 interfaces with OAuth 2.0 and OpenID Connect handling identity and a USCDI version 3 compliance layer validating incoming data. MRHN will also maintain a secure cloud storage and disaster recovery solution as a backup and ensure continuity of operations. MRHN can leverage cloud-based data to gain analytics insights and support strategic population health management initiatives, which is one of the requirements of HIMSS Stage 7 maturity, and this architecture lends to that level of scalability.
Implementation starts with the foundation, connecting rural sites to Epic Care Ambulatory, improving broadband and network reliability, and linking data through the central API gateway. We also standardize DAP and BERT documentation and remote monitoring inputs so they map to shared data formats. Semantically, HL7 supports real-time clinical events, while CCDA handles document sharing and care transitions. FHIR R4 enables app to EHR and wearable data exchanges. SNOMED CT, LOINC, and RX norm ensure consistent terminology. Organizationally, unified governance, standardized workflows, and improvement in MyChart adoption and wearable engagement are keys for success. We built 3 validation scenarios. First, external CCDA documents are converted to FHIR and added to the longitude chart, targeting 99.8 match accuracy and under 2 seconds processing time. Second, wearable glucose data arrives as FHIR observations, updating trends and triggering alerts with 100% timestamp accuracy and under 500 millisecond per payload. Third, HL7 version 2.5 lab orders and results target 99.9% match accuracy and less than 0.1 rejection orders. 0.1%.
Our consumer engagement strategy focuses on increasing engagement and strengthening proactive, equitable digital care. This includes improving MR Agent's digital infrastructure, simplifying MyChart enrollment and password recovery, providing digital support in clinics. Wearable data would also be better integrated into Epic so providers can use it to support chronic conditions like high blood pressure and diabetes. MR Agent can expand telehealth, use MyChart reminders, and partner with community organizations to improve digital adoption, particularly among older and rural patients. Finally, the Enterprise Consumer Engagement Council would oversee these efforts to attract MyChart's telehealth and wearable adoption.
Our usability testing focused on older and rural patients because these populations experience some of the greatest barriers to digital health adoption. Rural MyChart adoption is around 20% versus roughly 60% in metro areas. Older adults may have limited experience with portals and connected devices, and rural bandwidth can interfere with both portal access and device transmission. 8 adults age 65 plus participated in testing, 5 from rural communities and 3 with low digital literacy. Jane, Bob, and Kim represent the ranges of experiences, from needing family support to being comfortable with MyChart usage. Participants trained at the clinic used a blood pressure monitor at home for 1 week, then completed a questionnaire and interview. Here, Anne represents the use case, although all 8 participants followed the same steps. She signs into MyChart, connects the monitor, takes a reading, and confirms transmission. The result is stored in the EHR and displayed in MyChart. Abnormal readings or device issues trigger instructions and care team alerts.
We have phased this implementation over 24 months. Month 1 through 6 lay the foundation, rural upgrades, broadband, gateway integration. Month 7 through 12 handle standardization, HL7 feeds, CCDA sharing, FHIR APIs, and terminology. Months 13 through 18 focus on engagement, and months 19 through 24 bring governance and scale, unified data governance, TEFCA participation, and KPI dashboards.
To close, we have 4 recommendations: closing the rural gap, expanding broadband and rural healthcare access, standardizing data using FHIR, HL7, and CCDA, engage consumers through digital tools and wearables, and strengthen governance and measures. Together, these steps move MRHN towards a truly connected network. Thank you.
Thank you.